Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Tnfog Marathon Cme. So it's my privilege to introduce the MOCs of today's webinar, Dr. Gayatri N. Ma'am is the executive member of Triox and consultant at Shamla Nursing Home, Trichy. I welcome you, ma'am. And it's my pleasure to introduce Dr. T. Radhika Gauri ma'am. Ma'am is specialist consultant in OBG and clinical lead ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand the session to you.
Thank you, Sahiti, for the nice words. Good evening. Good evening, respected faculty, and Dr. Sampath ma'am, Dr. Vidya ma'am, and our esteemed chief guests. Let's start the marathon session for this week.
Yes, thank you, Radhika.
Thank you, ma'am.
Thank you. We will start the program.
Program.
Tamil
Tamil Thai.
Yes, we'll go with the
Lamp lighting.
Yes.
Good evening. Good evening, ma'am. Good evening, ma'am. I welcome Dr. Vidya Prabhakar, ma'am, who is the president of Tnfog for this year, 2025 to 26. She is the past president of OG Society of Salem.
Yeah, thank you, Dr.
And,
Radhika. So I think this audience does not know anymore.
Welcome, ma'am.
Yeah.
Welcome, ma'am.
Yeah, thank you so
And,
much.
let's
Thank you, Dr. Radhika. And yeah, so I welcome everyone for this lovely marathon CME. Now, these marathon CMEs have been going on for the last 3 years continuously. Every month we are having on the second Friday of the month without fail. And usually these marathon CMEs are dedicated CMEs in the sense that it is on one particular topic, probably related to that month, whatever is the day in that month. Like, for example, HIV Awareness Day, so it will be on HIV like that. And so this is for the benefit of the others who have joined. So it will be on a dedicated topic, and we will usually have, some UAs presenting. Initially, it will be the UAs presenting. And there will be two judges who are the same throughout the year. And at the end of the year, these UA presentations will be judged and awards will be given at the national conference. So this is actually to encourage the UA and to also, recognize their talent. And so there will be also update and a panel. Usually this is the structure of this marathon CMEs. And so that the whole topic is well covered. So the UAs will be talking about the advances and or the basics, and the updates will be given by senior faculty. So, and there'll be also a panel discussion wherein we have very senior members of our TNFOG participating, and we have two lovely hosts always, Dr. Radhika, who is always smiling and always ready, prompt with everything. and Dr. Gayatri. Both of them are lovely hosts here. And the whole program is the brainchild of Dr. Sampath Kumari ma'am. And it has been continuing without fail every month. And so with that introduction to the CME, I would like to welcome our chief guest today, Dr. Lakshmi Srikhande ma'am and Dr. Madhuri. Can we have their CVs? Yeah. So we all know, all over India, we all know about Dr. Lakshmi Srikhande ma'am. And she's the Foxy representative to AOFOG Asia Oceania Federation 26-27. She's FIGO committee member for climate change and toxic environmental exposures committee. She's chairperson, Indian College of OB-GYN 22-23, National Corresponding Editor Journal of OB-GYN of India, Jogi 2018 to 2026, National Corresponding Secretary, Association of Medical Women, India 2021-26, members of FOG Education Committee, Vice President National ISOPAP 2627, Joint Secretary Indian Menopause Society 2024, President ISOPAP Vidarbha Chapter, President Association of Medical Women Nagpur, and Madam, I think there is one more here in this particular side itself, President Menopause Society Nagpur 2016 to 18. Ma'am, we are extremely proud to host you here and we welcome you to be our chief guest. I'm sure you have lots of awards to your credit, laurels and awards and publications, and you've delivered so many orations and guest lectures all over India, and you're a very popular academician. So welcome, ma'am, for our CME. We are indeed blessed to have you here today. Can we have the CV of Dr. Madhuri?
Vidya madam, let her give the wishes, then we will go for Madhuri madam.
Okay. Yeah, ma'am, we welcome you, Dr. Lakshmi ma'am. Please share your thoughts, your blessings.
Thank you. Thank you so much, Vidya, for such kind words and your love and affection. And I'm really delighted to be here today. TNFOG has always been a shining example of strong academics and meaningful clinical work. And I congratulate the entire team for organizing such a rich scientific program. Today's sessions, from the UA presentations to the discussions on HIV, syphilis, and vulvovaginal infections, reflect the scientific depth and commitment of TNFOG. The thoughtfully curated topic addresses real, pressing needs in women's health and offer great learning for all of us. My warmest wishes to Dr. Sampath for the upcoming Foxy President election. May your vision and dedication take our organization to even greater heights. It is also a joy to share the dais with my dear friend, Dr. Madhuri Chandra. Moments like these remind me of the strength of our professional bonds and our shared commitment to women's health. I once again congratulate TNFOG for this wonderful academic feast and thank you for giving me the opportunity to be part of this memorable evening. Thank you.
Thank you,
Thank you
Lakshmi
very much,
madam.
ma'am.
Thank you.
Yeah, we are indeed blessed to have you here today, ma'am. Yeah.
Thank you. I am also enjoying your company.
Yes. All of us are in pink color, madam.
Yeah, I am also. Yes.
Yes.
This
Yes.
is Dil Se Connection, Sampath.
Yes. Vidya madam, introduce Dr. Madhuri madam.
Yeah, can I have her CV, please? So we take great pride in welcoming Dr. Madhuri Chandra ma'am for being guest of honor today. And she is a former professor, OBG, Gandhi Medical College, Bhopal. And she's affiliated to ICOG Governing Council 2017-19 period, President Bhopal Menopause Society, Chairperson HIV AIDS Committee Foxy 2014 to 2016, President AMPOG's Research and Public Welfare Committee 2015 to 2017. She has won a lot of awards. The 8 Jawaharlal Nehru National Solidarity Awards in 82. And she got first prize in promotion of institutional deliveries in the government of by the government of MP 2006-2007. And she's got lots of publications as well, and she has contributed to books. And her special interests are high risk pregnancy and labor, social obstetrics, adolescent health. Ma'am, we would really like to know about these things. Actually, quite an interesting thing. Social obstetrics, as well, you mentioned, because lots of people write high risk pregnancy and adolescent health, but you are also into social obstetrics. We would really like to know more about it. Welcome, ma'am. We are indeed happy to have you here.
Thank you, Dr. Vidya. And thank you, Tamil Nadu Society, and especially Dr. Sampath Kumari also for giving me an opportunity to interact with you today. HIV/AIDS, now that is something which very close, a subject that is very close to our heart. As you see, Dr. Lakshmi Shrikande has also been a chairperson of the HIV committee. I have been a chairperson of the HIV committee. And we feel that the more we talk about HIV in general and in mothers particularly, the stigma surrounding it and the hesitancy to go and get yourself diagnosed, investigated, diagnosed, and then maybe registered will go away. Infections as such, especially when they involve the reproductive tract and are sexually transmitted, have a stigma that not only causes physical pain, physical discomfort, but also a lot of mental harassment. Okay, getting the woman to come forward with her complaints. I see there is a long section on vulvovaginal infections, also making the woman come out with her problems, letting her talk about these very intimate issues becomes a little difficult sometimes. But most important is to inform our women about the barriers that are there. We break those barriers, come forward, get themselves tested, because we want to ensure that they do not transmit these reproductive or sexually transmitted disorders to the unborn child. And that mother to child transmission or parent to child transmission is what we are really worried about. So let's go with the ABC: abstinence, be safe, use condoms. And of course, if somebody has any of these problems, go forward, get yourself tested, and there is always treatment available. Thank you so much for letting me come and interact with you all.
Thank you so much,
Thank
ma'am.
you, Dr.
Actually,
Madhuri, ma'am. That's
yeah,
the reason we
Dr.
called. Both of them were HIV committee chairpersons, Dr. Lakshmi madam and Dr. Madhuri madam. Both of
Yes.
them were. Anyway, Dr. Lakshmi
So,
madam,
Yes, I'm here.
today you saw that news. Now, what is that in Sita Mari? What is going on? Anything?
I have not
They
seen.
have
Which
mentioned
news?
around more than 4,000 people are HIV positive, something. Are you
maybe
aware of
children.
it?
No. I will have to go through
In
it.
Bihar.
Yes, ma'am, in
Okay, no
Bihar.
problem.
Yes, in
Yes.
Bihar, there's quite a number of women and children specifically.
400
Mhm.
adolescent
Yeah.
children they have mentioned.
Yes.
Madhuri, are you aware of it?
This is a recent revelation, which
No,
is
Meera
I don't
is
know.
talking.
It's
Anyway,
a,
we will. Thank you, Madam Lakshmi, Madam and Madhuri, Madam. Thank you. We will go with the scientific session. Radhika, continue.
That's fine. So, thank you, Madhuri ma'am and Lakshmi ma'am. And we go on to the scientific session. So, we have our regular uh, faculties, Professor Dr. Shanti. She's the Department of Obs and Gynae, Savita Medical College and Hospital. And she is a student of MMC. And she's trained in ultrasound in Obs and Gynae, advanced infertility, advanced laparoscopy. She's also ALSO provider and instructor. And she's more than 25 publications, and her field of interest is endoscopy, high risk pregnancy, and advanced gynecology. She has many achievements, and she's an examiner for UG and PG and invited faculty conferences. Welcome, Dr. Shanti ma'am. And I welcome Dr. Kartika Prabhu ma'am, who is a professor of SRM Medical College Hospital, Pata Glatur, and she is also a student of MMC and she's done her MD from Jipper. And I said special interest in high risk pregnancy, gynae endoscopy, and midlife health. She's got numerous awards, Dr. A.V. Umaguchi Memorial Gold Medal, Dr. Asha Bakshi Award at the annual conference of ACE RCOG 2016, and she won the prize paper presentation for UA Foxy South 2011. in NIPSI 2013, gold medal winner from SRM 2020, Dr. A.L. Mudalia Training Traveling Fellowship and 20 national international publications. Got and she's a faculty in national regional conferences. Welcome, both of you, and take over the session. Please start the session.
Okay, thank you so much
Ma'am,
for the
can you please
introduction, madam.
introduce Dr. Sasirek?
Yes, madam. So moving on to that your session, the first speaker is Dr. P. Sasireka, who has completed her DJO and DNGOG and MBBS at Kanyakumari Government Medical College, then DJO at MMC, and then completed her DNB in E-Road Headquarters Hospital. So she is here today to give a talk on the reproductive needs of HIV affected women. Can we go ahead, Dr. P. Sasireka?
Yes, ma'am. Good evening to one and all present here, ma'am. I'm going to talk about reproductive risk in HIV positive women. First, overcoming the destruction and
Sasireka, are you
transformation.
going to PPT? Are you going to project or not?
Yes, ma'am. I already shared, ma'am, in the group.
You have to share now.
I already shared, ma'am.
No,
Okay,
it's not seen in the
do you
screen.
want me to share, ma, on behalf of you?
Mm.
Screen sharing.
Or you
Yes,
are going to share, ma'am?
Do you have a presentation in the laptop?
Yes.
Yes, ma'am.
Okay, can you please share it right now?
Yes, ma'am. 1 minute.
The time for your talk is 10 minutes.
Okay, ma'am.
Yeah.
I'll share.
Sasireka, இல்லனா groupல போடு.
Yes, ma'am. I already shared in the group, ma'am.
Yes, ma'am. I'm having the slides, ma'am.
Yeah, Sahiti,
Yes,
please.
Shakiti, then you share.
Okay, ma'am. You please mention next, ma'am, so that I can go to next slide. Thank you, ma'am.
Yeah, you can go to the next slide, I think.
Yeah, yes, ma'am. HIV is an immunodeficiency virus, so it can weaken the immune system. It's not curable, it's only preventable. Modes of transmissions, it is transmitted unprotected sex with an HIV infected person and transmission of HIV infected blood or blood products, then sharing of needles with contaminated with HIV infected blood, and mainly from HIV infected mother to her baby. In India, 2024, we'll have 2.56 million of people living with HIV and adult prevalence of 0.2%. Now we have a global trend in people acquiring new HIV infections. That is from 1990 to 2025, it reduced from 2.5 million to 1.3 million. In women living with HIV have the same desires, hopes, and aspirations as any other women. This includes the right to have safe pregnancy, effective contraception, and prevention of mother to child transmissions. We are having newer 4 prongs under NACP phase 5. Prongs 1 is primary prevention of HIV, especially among women of reproductive age group by IEC campaign, adolescent health programs, and school health welfare programs. And prongs 2 is prevention of unintended pregnancies among women living with HIV by family planning services. Then prevention of vertical transmission of HIV and syphilis during pregnancy. Adolescent care, the 3 key strategies are empowerment and education, comprehensive prevention, challenging norms, and integrated services. Risk factors for HIV transmission in adolescents are their peer exposure, environmental influences such as social and cultural, poverty and isolation. They are experimenting with risky behaviors like unprotected sex, alcohol, and drug abuse. They're having transgenerational sex and sex for money. And also they are having only limited knowledge about HIV and AIDS. So we have to educate about HIV is widespread and accurate. Everyone should aware of their HIV status. So effective policies and resources are allocated for prevention and treatment. How we reduce your risk of getting HIV? By using condoms, ensuring that your partner who are living with HIV are taking treatment, and using sterile needles and syringes for all injections, using pre-exposure prophylaxis to prevent getting HIV if you're having ongoing risk, including during pregnancy, mainly getting tested and treated sexually transmitted infections. We are having school health wellness program under Ayushman Bharat. We have to educate the adolescents, mainly physical and mental health, and train teachers act as a health welfare ambassadors, conduct sessions on various health topics. Then providing contraception on campus,
Sorry to
testing.
interrupt, ma'am. Kindly inform me to change the slide, ma'am. Can you see the slides, ma'am, which I'm sharing?
I'm changing my slides in my laptop, ma'am.
Ma'am, currently I'm sharing in this meeting, ma'am, on behalf
Okay.
of you.
Okay, ma'am.
So
Okay, ma'am.
kindly
Sorry,
inform
ma'am.
me to
Okay,
change
ma'am.
the slide, ma'am.
Okay, ma'am. Yes, ma'am. Providing contraception on campus and on-campus STA screening.
Is this the current slide, ma'am?
Yes, ma'am.
Okay, thank you.
Condom availability programs, online contraception providers, mobile health camps, and school clinic partnerships. They are all the strategies to improve the access to sexual and reproductive health services. And some strategies to improve the quality of sexual and reproductive health services are contraceptive counseling apps, then tailoring services for diverse students, text messaging for communication and education. Then coming to family planning methods, the purpose of family planning programs or methods for women living with HIV are to prevent unintended pregnancy, then optimize their health prior to getting pregnancy, improve maternal and fetal outcomes in pregnancy, and prevent perinatal HIV transmission also. Counseling for healthy timing and spacing of pregnancy. The three key messages about healthy timing and spacing of pregnancy are: first pregnancy should be planned only after the age of 20 years. After a live birth, next pregnancy should be planned only after minimum of 2 years gap. After abortion, next pregnancy should be planned only after 6 months or later. I'm coming to previous slide, ma'am. Healthy timing and spacing of pregnancy, for that they have to have a appropriate contraceptive follow the appropriate contraceptive method, and they should have a planning of pregnancy. All newly diagnosed HIV infected women in reproductive age group, they should be guided about ART and counseling as per established guidelines of NACO. Women living with HIV should plan pregnancy after achieving adequate ART adherence and sustain viral suppression, preferably achieve undetectable viral load. Next slide, ma'am. We have to consider some key points while counseling a woman for contraception. Mainly encourage the involvement of the partner also, then review the women's medical history, then discuss the effectiveness and safety of different contraceptives. Mainly we have to highlight the benefits of long-acting reversible contraceptives like IUCDs and implanon. Then we have to encourage the use of condoms, mainly to prevent the STDs. So dual protection. Next slide. As of uninfected women, HIV positive women also generally have the same option for contraceptions. Risk elimination model, we have to ask them to follow the abstinence. Risk reduction model, ask them to follow the condom usage, increase the usage of condoms. Harm reduction model, there is a needle exchange and substitutional therapies. Next slide, we are coming to contraceptive methods. First one is male condoms. It mainly used for barrier method of contraception and also additional benefit of protecting against the STDs. Then condoms can also be used with other contraceptives as a dual method. Then coming to female condom, it's an internal condom. It worn inside the vagina to prevent the pregnancy and also mainly for HIV and other STDs. 95% effective with perfect usage. Protection improves when used correctly every time. Next slide. In coming to oral contraceptive, next slide, we are having hormonal pills and non-hormonal pills. In non-hormonal pills, we are having combined oral contraceptive pills and progesterone only pills. In non-hormonal, we have synchromon. Next slide. We have OCPs, we have interaction with some ART drugs. Mostly toludragavir women with taking toludragavir based ARTs and NRTA based ARTs, there is no interaction with OCPs. So OCPs with safe with that females. Women's
Doctor,
with
only 2 minutes left.
Okay. Next. Yes, ma'am. We are having the consideration for PL-HIV on different methods of contraception. Already existing IUCD users having new HIV infections, they need not to remove the IUCDs. But with advanced or severe clinical illness, they can keep IUCDs, but should be closely monitored for PIDs. Women with HIV, they are going to use IUCDs newly means they can safely undergo for IUCDs with mild or no clinical HIV disease. Should not undergo IUCDs for active infections and PIDs. Next slide, safely given, Antara can be safely given. Female sterilization, safe is suitable, but can be delayed in active STDs or PID infections. Referral and linkages for family planning services is very, very more important in counseling the couples to adopt the family planning services. So PLHIV should be provide knowledge in respectful and non-judgmental and confidential manner. Women living with HIV with unmet family planning needs should be referred to health facility providing family planning services. Next slide, ma'am. NACP phase 5 goals are reduce annual new HIV infections by 80%, reduce AIDS-related mortalities by 80%, eliminate vertical transmission of HIV and syphilis, then promote universal access to STDs, eliminate HIV-related stigma and discrimination. These are all done by primary prevention, by educating the women and adults, by adult welfare health clinics and school health programs and IEC campaigns. Then mainly next thing is adopting them to family planning methods to avoid or prevent from STDs and avoid unintended pregnancies. Our main aim is more than 95% of the people should aware of their HIV status, of which more than 95% should have on HIV treatment, of which we have to decrease the viral status more than 95%. Thank you, ma'am.
Thank you, Sasrika. It was a good presentation. So any
Yes.
women with HIV is no contraindication for a reproductive needs. Yeah. So you said like before embarking on pregnancy, they should be fit enough to go on to a pregnancy. What is the level? Like what is the criteria? Do you have any criteria to prevent baby from acquiring the infection or a parent to child transmission?
Mostly undeductible viral load should be there, ma'am. It will be good for maternal and fetal outcome, ma'am.
Okay. Okay. Okay, sir.
We are going to prevent mother-to-child transmission.
Yeah.
This will be discussed by Dr. Arunachalam sir later, ma'am.
What contraception you will like to advise?
And to avoid, mostly we should encourage them to follow the long-acting contraception like IUCDs or Antara injections with the dual protection with condom, ma'am, to prevent from STDs.
So dual protection is better than
Yes, ma'am.
single.
Yes, ma'am.
Ma'am, kindly introduce our next speaker, ma'am.
Yes. The next speaker is Dr. Divya. Dr. Kartika, are you introducing her? Hello.
Yes.
Okay.
Yeah.
Next speaker is Dr. Divya. She is a consultant obstetrician and gynecologist, lab surgeon from Sarvesh Medical Center. She did her UG in Tanjavur Medical College. She has done MRC UG, Diploma in Minimal Access Surgery. She has more than 14 years of experience in OBG. She has special interest in menopause, urogynecology, and lab surgeries. So she is going to talk on social impact on sexually transmitted infections. Over to you, Dr. Divya.
Ma'am, I've already shared the slide. So is anyone sharing my presentation or should I share from my laptop, ma'am?
Please share from your end, ma'am. Yes, ma'am. We can see your slide, ma'am. Please make it as full screen, ma'am.
Yes.
Yeah, perfect, ma'am. Thank you.
Good evening, everyone. When I received this topic, can changing social trends result in a resurgence of STA? I was little surprised, and when I went into literature, yes, there is an increasing resurgence of sexually transmitted infections, and because of the social trends, and these few of the social trends we are not yet aware, and there are many social trends, and which tells us that we have to change our way of surveillance and treatment so that which it can be reduced. So rising incidence and re-emergence, when we say resurgence of STA, it is actually a noticeably increase in the incidence of this infection, or the infection which was already declining is again coming up, or the emergence of new pathogens which is were not considered as traditional STA previously. So it is rising again in many parts of the world. It is we have better diagnostics and better treatment than ever, but still we have rising trend. But the rise is closely connected to how our society is changing, especially in the last 10 to 15 years. So we have to understand these changes so that we can have effective prevention strategies. So globally, HIV, viral hepatitis epidemics, and STA continue to pose significant public health, which leads to 2.5 million deaths each year, according to the WHO report. So it is actually which is transmitted through the sexual contact. More than 30 different bacteria, viruses, and parasites account for this STI. But among them, 8 pathogens are linked to the greatest incidence. Among that 8, 4 are curable, like syphilis, gonorrhea, chlamydia, and trichomoniasis. The other 4 are like hepatitis B, herpes simplex, virus, HIV, and human papillomavirus pose a major risk. So this is a rising trend of syphilis. Among the 4 curable STIs, they account for 1 million infections daily, and there is an increase in maternal syphilis as well as congenital syphilis. In addition, there is an emerging outbreak of new infections such as Mpox, Shigella soni, Neisseria meningitis, and Zika virus. And there is also a re-emergence of neglected STIs such as lymphogranuloma venereum. So emerging STIs show us that STA landscape is expanding, and the changing behaviors make it easier for new infection to spread. These are the infections of Mpox, Tinea genitalis, and tuberculin. So currently, there is a resurgence of syphilis and emergence of drug-resistant Neisseria and gonorrhea. The interplay of various factors results in this resurgence, and they may act as alarming sign of impending epidemic. So this drug-resistant gonorrhea is resistant to multiple antibiotics. Resistance spreads more rapidly when the infection circulates widely in communities. And there is a new data which says that within the surveillance, the elevated levels is like from 5% to 40% resistant to ceftriaxone, which is the treatment for gonorrhea. And WHO is monitoring the situation and updated its recommended treatment to reduce the spread of this multi-resistant gonorrhea strain. In 2022, 1.2 new Hep B cases and nearly 1 million Hep C cases were recorded. So the estimated deaths also rise from 1.1 to 1.3 million. So differences in trends by geographical region and age groups points to the need for more targeted prevention strategies in key regions and populations. So new HIV infection only reduced from 1.5 to 1.3 in 2002, but the 5 key population groups such as men who have sex with men, people who inject drugs, sex workers, transgender individuals, and individuals in prisons and other closed settings still experience significantly higher HIV prevalence rate than the general population. An estimated 55% of new HIV infections occur among these populations and their partners. HIV-related deaths still continue to be high. So in 2022, among the deaths, 13% of them is occurring under the age of 15 years. So role of social trends. So we need to know about the social trends which is happening right now. So behavior shaped by the society refers to the shift in the way that people interact, form relationship, date, communicate, and live. So these trends influence the sexual behavior and therefore influence the STI transmission. So one major social trend is changing sexual norms. So more people engage in premarital relationship, they begin sexual activity earlier. Social acceptance of casual sex has increased, and all of these changes expand sexual networks and increase opportunities for transmission. And these dating apps have transformed how people meet partners, and they remove the social barriers, and they allow quick connections, short-term relationships, and anonymous encounters. This also increases the partner turnover and makes STI spread faster. So digital connectivity, it also makes people meet easily outside the social circles, and anonymous profiles and convenience reduces the hesitation, and this expands the sexual networks and increases transmission. Urbanization, there is a rapid urbanization, which means people live in crowded cities away from the traditional support system, and that encourages the mobility, independence, and new relationship, all of which influences sexual behavior. Migration, where for education, jobs, or economical reasons, break down the traditional family and social structures. So who migrate often have new freedom, anonymity, and exposure to different cultural norms, which may shape sexual behavior. So delayed marriage, experimentation among the young people, they have more opportunities for social interactions, like college campuses, workplaces, travel, and nightlife, all create environments where new relationships are formed frequently. Media influence, which actually makes the sexual content normalization. Media, movies, and social networks have normalized certain types of sexual behavior. Young people often receive messages that glamorizes casual relationship. The risk perception becomes lower, leading to less protective behavior. And substance use along with alcohol has also reduced the judgment and lowers the likelihood of condom usage, which in turn increases the risk of STI. So party environment combined with sexual networks with substance use. There's a trend called chemsex, where sexual activity takes place under the influence of specific drugs. These networks have been associated with high rates of HIV and other STIs. Condom use decline. It has been in the young people often rely on emergency contraception or trust partners, and older adults feel they no longer need condoms after menopause, not realizing the risk of STI. And multiple partners increases the number of connections between sexual networks, and this makes STI spread more quickly, even if people think they are being careful. And older adult STIs. There is a rise in STI among older adults because with longer life expectancy, diverse, and new relationship after 50, this age group is now more sexually active, and many do not use condoms because pregnancy is no longer a concern. And LGBTQ trends, they have higher connectivity, especially among MSM communities. Does not mean the communities are at fault, but the network structure allows infection to circulate more rapidly. Digital misinformation, like unsafe practices spread faster. So social media spreads misinformation about sexual health, and you only need testing if you have symptoms or STIs are not serious. So this reduces testing and increases the undiagnosed cases. So healthcare access, poor access delays treatment. So access to healthcare services still limited in many places. So testing centers may be far away or too expensive, or may feel embarrassed to go. Delayed diagnosis increases the spread. There is always a stigma, like one of the biggest barrier. Avoid testing, avoid discussing symptoms, and delay seeking care because of shame. The silent spread contributes to resurgence. And because of COVID, there was a shutdown of all the centers, and it led to a sharp rise. And economic factors like poverty or transactional sex, financial difficulty may engage in transactional sex or unsafe relationship. Poverty and inequality manifests as a risk. And coming to the gender inequality, now, women often have less power to negotiate condom use. Social pressures and safety concerns limit their autonomy. So this makes women particularly vulnerable to STI. And public health gaps, like underfunded sexual health programs, lack of trained staff, and weak surveillance means that that many cases remain undetected. Without good public health infrastructure, resurgence is inevitable. So targeted digital campaigns, we need targeted interventions such as working with dating apps, using social media campaigns, offering self-testing kits, reducing stigma, and public health must evolve to stay relevant. So not all social changes uniformly increases STI. Sometimes increased awareness, better diagnostics, education, safer sex practices can counterbalance the risk, but the outcome depends on the social context, public health infrastructure, and behavior. So the interplay is complex. Resurgence will look different in different geographies. the trend for viral STIs is increasing while that for bacterial STIs is decreasing. So proper training of the healthcare providers like for minor STA, condom promotion, partner notification, partner management, counseling regarding venerophobia should be undertaken to make STA control program successful. The WHO response is like it is currently guided by the Global Health Sector Strategy on HIV, hepatitis, and sexually transmitted infection 2022 to 2030. So within this framework, it develops a global targets, norms, and standards for the STA prevention, testing, and treatment. It supports the estimation and economic burden of STA and strengthening of STA surveillance. It globally monitors resistance to gonorrhea and leads the setting of global research agenda on STA, including the development of diagnostics, tests, vaccines, and drugs for gonorrhea and syphilis. So as a part of its mission, WHO supports countries to develop national strategic plans to scale up the primary prevention, increase integration of STA services with primary healthcare, increase accessibility of people-centered quality STA care, facilitate adoption of point-to-care test, and enhance and scale up the health interventions for impact such as Hep B and HPV vaccination, syphilis screening, and strengthen the capacity to monitor STA trends and monitor and respond the resistance in gonorrhea. So, conclusion, social trends drive STA resurgence. To conclude, social trends strongly influence sexual behavior, and sexual behavior drives STA transmission. Changing norms, technology, mobility, and healthcare gaps together explains the resurgence we are seeing. So, understanding these trends allows us to design better intervention.
Divya, it was a very good talk. So you have covered almost all topics. I think you didn't leave any stone unturned, right? It was a very good talk. And so today there is no concept like Urban Kurti, right? Except the boomers who are still sticking on to it. The newer generation is completely different. Their perspective towards sexuality has changed, right? So anything more to say? Anyone wants to add? Dr. Karthika?
What is this LTBCQ trend?
Ma'am?
What is the LTBCQ trend?
Ma'am, that is...
you told no? You mentioned about some...
lesbian, gay, bisexual, all those group, ma'am, transgenders.
Okay, so because of the social change in trend, there is resurgence of sexually transmitted infections. How we can prevent that?
We have to the previous old model where treating the partner alone will not help, ma'am. Detailed surveillance, detailed history taking, and not only that, we have to reduce the places where it is being spread and all. We have to mainly create awareness so that it is being under control. People
health education is very important. Health education and creating awareness.
And also treatment also, it's like will not stop with the treatment of husband or wife alone. It has to be detailed. Like we have to ask a personal history to rule out all those the root causes and all.
Good presentation, Divya.
Thank you, ma'am.
Hello.
Yes, ma'am.
Yeah, ma'am.
The chairpersons, ma'am.
Yeah, I'm here.
Dr. Vidya ma'am is our president in Tnfog 2025 to 26.
Oh, yeah. You want me to take over as a chairperson, the next one, isn't it?
Yes, ma'am. Yes, ma'am. Welcome
I think
you.
we have to welcome Dr. Saravanan. He's not there?
He's here, ma'am. He's there.
I'm here.
Yeah.
He's the treasurer of Tnfog for the current tenure.
Yes. We will start.
Over to the chairpersons.
We'll start the session.
Yes.
So,
Yeah,
Dr. Arunachalam. He is a fellowship in HIV medicine at CMC Vellore. He is a senior ART medicine medical officer, Government Hospital, Salem. He is the district program manager for district AIDS prevention control in Salem. He presented NACO ART guidelines for adult and children. His awards, honors, and achievements are in Salem ART Center was appreciated by NACO for innovative differentiated service delivery in 2018. It was implemented all over India in 2021. He got the Best Doctor Award received from the government of Tamil Nadu in 2019. Salem DAPSU was awarded by TANSAX as the Best DAPCU in Tamil Nadu in 2019. Over to you, sir. He'll be talking about elimination of vertical transmission of HIV and syphilis. So we don't want any child to be battling their life as soon as they are born. Where something which can be eliminated totally are almost reduced to less than 1% by taking appropriate measures. Thank you, sir. Thank you for accepting our invitation. Madam.
Welcome, Dr. Arunachalam, sir. So we are indeed happy to have you here because you are a dynamic person and we would like to know it from the horse's mouth. So to speak. So this update has to come from an expert. So that is why we have welcomed you here. Over to you, sir.
Good evening to all. Thanks for the introduction and thanks for this opportunity to share my presentation in this forum, ma'am. Actually, because of World AIDS Day, we have to. One of the important topic is elimination of vertical transmission of HIV as well as syphilis. Initially, National AIDS Control Program mainly focused on HIV per se. Now it's in the NACP 5, National AIDS Control Program Phase 5 program. We have included the syphilis also. So syphilis also it's reassurance there. Congenital syphilis, so many cases reported now. So we have to give more importance to syphilis also. That's why we are talking about HIV and syphilis in the both the vertical transmission. Thanks, madam. Vertical transmission, we know that very well about spread of infection from mother to child occurs during the pregnancy in utero, as well as during labor and delivery, perinatal, and as well as postpartum through the breastfeeding. So both the disease, HIV and syphilis, may be transferred in the same mode of transmissions. Then vertical transmission of HIV and syphilis, especially HIV infection in among infants and children, over the half of children, if it is HIV infected CAA, that is children infected with HIV/AIDS, there is less than 2 years they die if the HIV is not diagnosed early, not put on ART early. So this is the time to take up to either to prevent the HIV infection in the children, as well as if it is infected, this infected child should be on treatment as early diagnosis and treatment is possible to reduce the death of the children. This is our motive. The second thing is syphilis. You know that syphilis infection pregnancy, so the adverse birth outcomes, abortion, miscarriage, and then stillbirth, lot of congenital developmental delays, deformities in the children. So this is our mission of the National AIDS Control Organization in all over India. We have to put on to prevent HIV and syphilis for the newborn. Next slide, madam. Next slide, please. So important key goals. So we know that reducing the mother-to-child transmission rate of HIV to less than 10% of the among the breastfeeding populations. Then also less than 2% in non-breastfeeding population. We know that breastfeeding itself increases chance of risk of transmission, but even in the modern era, breastfeeding, we know the importance of breastfeeding, advantage of breast milk over the other artificial formula feedings. So we are, as per government program, we are encouraging the normal breastfeeding, even though with the ART, still there is a little bit increasing chance. So now it's without our intervention, any prevention activity, natural course of disease, 20 to 40% of children may get HIV from the mothers. So 60% of the percentage of getting non-HIV children. So still with our effect from early testing, diagnosing, linkage to the care, ART initiation, follow-up, and total comprehensive continuous follow-up, we have to reduce the infection to less than 5%. Now it's up to less than 1%. Now it's practically saying in Tamil Nadu, we are reducing less than 1% actually. We are reaching the more advisable level in Tamil Nadu. Second thing is new pediatric infection case rate, maintaining case rate less than 50 per 1 lakh live births. This is our motive. Then also same thing for congenital syphilis also, less than 50 per 1 lakh live births. Next one. Next slide, please. Yeah. Already previous speaker spoke about the 4 prongs of PPDST, but it's my topic is on the third prong actually. First prong is primary prevention of HIV. That is HIV negative adolescent or adult girls should be educated and before getting married itself, as well as if the mothers or any woman is free of HIV infection, there is no chance, almost 100% prevention of mother-to-child transmission. The mother is positive, then only the chance there is a little bit chance of to transmit to the infants. So we are focusing on adolescent girls and women through the adult reproductive sexual health. So through school health programs and other various programs. We are focusing the primary prevention of HIV among the women, especially. Second prong, if the woman is infected with HIV, then we have to prevent unintended pregnancies. So our previous speaker spoke about the various modes of contraception. We are focusing on non-pregnant mothers, family counseling and contraceptions in the ICDC as well as the ART center. We are focusing to avoid unintended pregnancies. We are focusing double contraceptions, using the condom with other socially acceptable other contraceptions. So male condom as well as female side. We are covering the dual partners. Male use the condoms, female either oral contraceptive pills or UCDs or any other alternative methods to prevent unintended pregnancies, to avoid unnecessary transmission of mother to child transmissions. Newborn child may got the infection. Now it's my topic is focused on prongs 3. The woman is already HIV infected as well as become pregnancy. So now pregnant positive women, you have to give more antenatal special care to the antenatal checkup through ART treatment. It's a comprehensive care from ICDC, ART, OG department, field activities through ASHA, VHNs, then care and support center, CSE. Those are all working in the field outreach activity to set up our linkage and referral system, then prevents to improve the maternal health as well as to decrease the chance of transmission to the child. So take care of these mothers. Prong 4 is after getting delivery, we have to take care of the child also, with the help of pediatrician as well as ARV prophylaxis, breastfeeding habits, post-rheumatoid prophylaxis, yearly diagnosis. Using in government program, we are using the PCR testing only for those newborns, those who are born to HIV positive mothers. So early diagnosis, if it is unfortunately, if it is transmitted to the child, we have to put on ART for the child as soon as possible. That's also our motive. This is our basic underlying program. Next slide, please. So, in coming to OG point of view, we are a pregnant woman with the woman living with HIV infection is considered to be a higher risk of pregnancy. Should be provided following services: extended PMSME, that is Pradhan Mantri Surakshana Mandra Bina Care. These components of for high risk pregnancy. So then, birth planning is essential. Care given to the pregnant woman with HIV for safe delivery and prompt management of complications, if any. Then institutional delivery is must for all. All identified high-risk pregnancies must be linked with the nearest first referral unit, ANM or ASHA, to support this activity. Then outreach and patient tracking by CSE. The prioritizing tracking of pregnant women living with HIV for adherence, ART adherence, viral load suppression, and ARV prophylaxis for the baby's prescription prior to the birth of their infant itself, we have to decide. This kind of comprehensive continuous effort should be taken for the pregnant women. Next slide, please. Then what are the strategies for this EVTHS, elimination of vertical transmission of HIV and syphilis? First is family-centric approach to the ANC. Not only ANC, their spouses to be counseled, family members, even in-laws as well as in the parents, because during the ANC period, patient ANC may be living with the children, then after delivery, mother should be maybe in their mother's house. We have to counsel regarding HIV, AIDS, and then this program activity, everything should be the family members. Everybody should be aware about it. Even though it's confidentiality issues there, we have to motivate the mothers to disclose their status to their closest entity to give comprehensive approach for without interruption of treatment also. Second one is adherence to treatment. So early initiation of ART, that is early diagnosis of pregnancy among the HIV positive mother. Either in the first trimester itself, we have to identify. Even we have to start ART at the earlier itself. Even in first trimester, initially we are prophylaxis only during the delivery itself. We are before delivery we give the single dose nevirapine for the mothers. Now it's early initiation of triple drug ART, highly active antiretroviral therapy, at even the first trimester itself. So then continue adherence to treatment is very important throughout their period, throughout the ANC period, during the delivery as well as postnatal breastfeeding period and lifelong, they have to follow the good adherence. So outreach support through the care and support center, which is run by the PLHI network people in the local districts. And importantly, special care for the viral load testing. Usually in viral load testing for the HIV positive patients, 6 months once or yearly once, we are doing the screening test, viral load testing to find out the virus response to the treatment. In case of this case of pregnancy, we have to do another as per routine, we have to follow yearly once, annually viral load testing. But apart from that, we have to do viral load testing 30 to 36 weeks of the pregnancy. So at that time, we have to find out the viral load suppression level in the mother. So counseling on breastfeeding, ARV prophylaxis, family planning, contraception, everything should be decided in the ANC period itself. So finally, retention of ART. So entire promoting institutional deliveries and retention of ART for lifelong for the mothers, for the benefit of mother as well as child. Next slide, please. So steps to reduce the risk of HIV transmission to the babies. So important, we know that important transmission route for new HIV infection in children is mother to child transmission. Even though it's other child abuse, sexual abuse or blood transmission is rarely reported, but here mother to child transmission is the most important factor for important route for new infected HIV infected children. Is CIA, children infected with HIV/AIDS. It's a important mode of transmission, vertical transmission. So as well as late detection, already I discussed about if the child is infected within 2 years, 50% over the 50% of children are expired without diagnosis. So early diagnosis of HIV infected children is very important. So highest risk of HIV transmissions during childbirth, even though during the ANC period, chance of transmission is only 5%, but more than 90% of children are getting HIV infection from the mother to child during the childbirth. So this is highest risk. Then we have to take care of that area. Risk depends on HIV viral load in the mother's blood. Since multiple factors are contributing to prevent to transmit the infection from mother to child. Most important and most significant issues at the time of delivery, the mother's viral load is very, very important. So if the viral load is high, more chance of transmission for the baby. So we have to give ART throughout the ANC period to reduce the viral load. That's the more motive. Then the importance of viral suppression during the pre-pregnancy, pregnancy, and throughout the breastfeeding also. Even though breastfeeding, breast milk also having high virus. So we have to suppress the viral load, unsuppress viral load, make a chance to increase the transmission. So we are encouraging normal breastfeeding along with the ART. ART should be taken regularly. And that viral ART also, their drugs should be responded to therapy. Viral load should be suppressed level at any point of time. Viral load suppressed in blood, maternal blood, as well as other factors, vaginal fluid, amniotic fluid, other body fluid like breast milk, and everything should be on suppressed level. So we are focused on during pregnancy, that is ensure ART adherence and safe sex practice is important. Then childbirth, institutional delivery ensures precautions for the mother and baby during childbirth. ARV prophylaxis for the HIV exposed baby to cover the HIV exposure during the birth. Then U equal to U is that it's very important. Virologically unsuppressed extended duration ARV prophylaxis. We will discuss in the next slide. Next, please. This is the ART regimen preferred for the pregnant woman. All over, even in adolescent, you are more than 10 years age of adult or adolescents, we are giving the TLD tablet. TLD is tenofovir 300, amlodipine 300, dolutegravir. This is the simplest regimen. It's more than 30 kg. Anybody is having take one tablet once daily. This includes, it will act against HIV1, HIV2, or HIV1 and 2 co-infections. Women already exposed to the ARTs or real HIV co-infected with the TB or hepatitis B, C, multiple co-infection, it's easily accepted level. So all the pregnant women, even in first trimester, we have to start TLD to all the pregnant women. We are prescribing all over India. We are prescribing TLD for the pregnant women currently. Next slide. So how does ART work for preventing vertical transmission? ART improves maternal health, prevents HIV virus replication in the body. ARV enters baby through the placenta. So viral replication, the baby also prevents replication, reduces the maternal viral load, achieving viral suppression, lower the risk of transmission. U equal to U is important. So if the viral load is undetectable level, it's a risk of HIV transmission become negligible level. Next slide. So counseling messages for pregnant women living with HIV to reduce the risk of transmission. So many points there where I discuss in significant selected points. Number one is put on advantage of early ART and putting ART regularly. Then the second point, adherence during the entire period. It's important. Then safe sex practice to avoid fresh HIV or other STI infections to throughout the body. Counseling regarding regular ANC care, then selecting feeding options, nipples care, breast care, the nutritional care, then iron folic acid supplements area. Already we discussed the viral load testing at 30 to 36 weeks, institutional delivery, ARV prophylaxis for the baby, everything discussed. The final one is baby screening. Baby should be eliminated the HIV infection with the confirmation of HIV test finally at the 18 months or 3 months after stopping at the breastfeeding. Next slide. Next, yes. Intervention to reduce the risk of transmission. So maternal under the coverage of maternal ART, the care given to the HIV infected mother and their babies is similar to care given to the uninfected mothers and babies. So almost no need for any other special ANC care or nothing else. So mother should be taken ART. ART should be viral load should be undetectable. This is our motive. Then discovering other during the delivery, we have to follow the safe delivery mechanism. The discharge precautions to be adhered to that. Minimize vaginal examination, avoid prolonged labor, consider oxytocin to shorten the labor, avoid artificial rupture of the membranes, use non-invasive fetal monitoring and avoid invasive procedures, support perineum and avoid routine episiotomy. These are all the risk of getting exposure to the blood or other amniotic fluid, prolonged exposure to the vaginal fluid. This should be minimized. So avoid instrumental delivery as much as possible unless it is indicated. Better give second stage of labor should be shortened. That is our motive. Mode of delivery in India, normal vaginal delivery is considered unless the woman has substantive complications, indication for cesarean like fetal distress or fetal labor. HIV is not an indication for vaginal delivery. Next slide. So if the mother pregnant woman directly in labor ward, so far patient not registered to any government sector or any ANC period, so far not doing HIV testing. At the time of labor ward itself, we can do the whole finger prick test. We have point of care test that is rapidly, easily available, simple like blood glucose, glucometer level, dual rapid test kit for HIV and syphilis we can do at the labor ward. If it is positive, confirm with ICDC and ART starting. Otherwise, you can do the normal delivery. In case of positive, even in the time in the holidays or in the night, if you are not able to find out the ART center or ART institution, if there is no time to that, we got to put start TLD tablet at the labor room itself. Single dose TLD, it will decrease the viral load at the time of delivery. So even during the labor pain, we can start the single dose TLD for that lately detection cases also. So mother should be linked to the ART center and initiated the ART at the earliest. Next. So actually, immediate care at the birth for the newborn baby, usually under the cover of maternal ART, there is no difference in care given in birth and is similar to that of given uninfected mothers and their babies. But usually do's, what is the do's and do's? Do's are wipe the mouth and nose as soon as baby is delivered. Cover the cord with the gloved hand with the gauze before cutting. Cord clamping should not occur. Don't milk, that is don't avoid milking of cord is be avoided. Then already don'ts, avoid multiple vaginal infection examinations, invasive vaginal monitoring, avoid suctioning and everything. So as usual, within 1 hour, ideally, we can start the breastfeeding or their options. So universal precaution for the healthcare providers to be followed with the entire procedures. Next slide. Over 5 minutes more. Next slide. Infant feeding options to be discussed in the ANC period itself. Healthcare providers and counselors should help the parents in reaching the right decision to them. We are motivating them exclusive breastfeeding, only breast milk, no other food, fluid or water. Even we can medicines or prophylaxis, we have vitamin supplements, we can advisable. It may be permitted. Then exclusive replacement feeding, no breastfeeding at all. So animal or dairy milk or infant milk or hygienic preparation should be educated the patients and caregivers. Feed by bowl or spoon and no bottle feeding is there. No bottle feeding is very important for exclusive replacement feeding. So mixed feeding should be avoided. Mixed feeding increases the risk of transmission. Mixed feeding increases the risk of transmission of HIV and should be avoided. So we know that After giving the formula feeding, you can get more if the mother is again giving breast milk means more chance of transmission from gut. HIV invasion from the gut is more easy than exclusive breastfeeding. Next slide. So counseling message, counseling exclusive breastfeeding for the first 6 months of life is recommended. Then complementary feeds after 6 months along with the continued breastfeeding. Breastfeeding is encouraged for at least 12 months and may continue up to 24 months or more, even more, as usual, similar to the general population. Ensure mother is practice safe sex and good, having good adherence to treatment. Viral load should be suppressed at any point of time. This is important. So mixed feeding should be avoided. We are encouraging normal breastfeeding for first 6 months, then gradual complementary feedings after 6 months. We can continue as per patient needs. Next slide. This is now let us see how we are giving ARV prophylaxis for the HIV exposed infants. So initially we are giving only single dose of nevirapine for the baby. Now we are giving 6 weeks or 12 weeks based on the risk of transmission. We are categorizing the infant low risk transmission, high risk of transmission. Low risk of transmission means patient mother should be on maternal ANC periods of ART. 30 to 36 weeks. Viral load should be less than 1000 means we are giving single drug therapy for 6 months for breastfeeding or exclusive breastfeeding child. If the high risk of HIV transmission is, if the patient is not on ART or viral load is not done or viral load report is more than 1000, or we have to give dual prophylaxis, 2 drugs for the breast, 2 drugs for 6 weeks for exclusive replacement feeding, 2 drugs for 12 weeks for breastfeeding. So replacement feeding is a shortened period of prophylaxis to minimize the risk. Next slide. So infant prophylaxis for low risk infants, we are giving either the nevirapine syrup or Girovidin. Nevirapine will be used for HIV-1 infection. Girovidin will be used for HIV-2 as well as HIV-1 and 2 combined infection also we are using. So already failure to nevirapine means already exposed to nevirapine, we are giving Girovidin. In case of this kind of duration, this is the duration already I said 6 weeks. If the Girovidin syrup is not available, we can use the syrup lopinavir, tenavir. Should be used after 14 days of birth. First 2 weeks should be avoided. Lopinavir. Next slide. This is for high risk infants where we have to give dual prophylaxis, nevirapine and Girovidin. In low risk category, either nevirapine or Girovidin. Here is nevirapine and Girovidin. In case of replacement feeding, only 6 weeks. In case of exclusive breastfeeding, till 12 weeks we have to give. Next slide. No? Yeah, this is dosage of nevirapine up to 6 weeks based on birth weight 2 to 2.5 kg, 1 ml daily. More than 2.5 kg, it's 1.5 ml OD. This is up to earlier ages. We can add the doses based on their baby's weight. Next slide. This is dosage schedule for Girovidin. Nevirapine once daily, but Girovidin is twice daily we are giving. So less than 2 kg, 0.5 ml BD. 2 to 2.5 kg, 1 ml BD, more than 2.5 kg, 1.5 ml BD. These are all for 6 weeks further. Next slide. So coming to immunizations, as per our routine immunization can be given for all exposed mother babies, unless otherwise severely immunocompromised, like IUGR, preterm baby, low birth weight, any sepsis, any chance of seriously infected means you have to live vaccine, attenuated vaccine may be contraindicated. Otherwise, live healthy term, normal healthy active score is good, a child is healthy, we can give routine vaccination in spite of HIV infection. So we have to add rotavirus vaccine can be to reduce the risk of diarrhea in this kind of children. Then in case of Japanese encephalitis area, endemic area, we have to give the vaccination against JE infection. Next slide. This is a routine vaccination schedule, immunization, vitamin A supplements, birth 6 weeks, 10 weeks. Everybody knows about routine vaccination. In this case, vitamin A as well as JE also is very important. Next slide. Next, this is to come back to syphilis. In case of syphilis, if you are diagnosed syphilis in the most of them our government sector, we are screening at the ANC period at the PSC itself. Primary health center, we are a pregnant woman, all pregnant women screened for dual rapid test kit. That is only screening test, not we don't know dilutions. Whether it is HIV positive or syphilis positive. If syphilis reactive, give single dose injection benzathine penicillin 2.4 million units IM at the immediately at the nearest area. Then confirm with the dilution, RPR, VDRL, in serial dilution, we have to confirm. If it is found reactive, give another 2 doses. Totally 3 doses on weekly apart. So 0 week at the PSC level, first week or second week at GH or medical college level or any delivery site, we have to give injection benzathine penicillin 2.4 million units IM at weekly intervals for 3 weeks. This is the routine treatment for ANC syphilis. In case of medical college or any higher center, directly we are screening with RPR VDL, go for 3 injections at the same time. So within the matter of totally 15 days, we have to give the 3 doses of treatment. So follow up after that treatment, we have to give after 3 months or 32 weeks of pregnancy or labor, whichever is earlier, we have to do the RPR VDR testing. So both the thing before treatment and after treatment, 3 months after treatment, we have to compare that. This titer either at the same level or increase. We have to suspect the treatment failure or reinfection, go for another 3 doses injection. If the titer is less or response to therapy, either RPR is non-reactive or 4 dilution, 4 deep dilution decrease level, we have to think about cure of HIV, cure of syphilis. Then we have to follow the child, institutional delivery and assessment of the infant. Excellent. This is a syphilis exposed infant. If the infant born to which is syphilitic mother means we have to screen by the pediatrician after birth. Pediatrician to examine physical exam assessment and examination. You will find out the chance of either a syphilitic baby or congenital syphilis is there or not. Then clinically as well as VDRL test should be done for mother and child at the same time after birth. So the child mother infant is symptomatic. There is evidence of congenital syphilis, then infant's RPR titer is 4-fold higher than mother titer. Either one, either if child is symptomatic or RPR is titer is more than 4-fold. This diagnosis is a diagnosis congenital syphilis. Give curative treatment, that is injection benzyl penicillin. Child should be admitted in the ward. Give 10 days of benzyl penicillin or procaine penicillin in the ward. Then, if the child is asymptomatic, child is healthy, no evidence of syphilis, then RPR titer also not 4-fold increase than mother titer. Then it's chance of cure. If the mother is past history is important, mother is received appropriate treatment, 3 weeks of therapy means no evidence of last reinfection, giving prophylactic treatment, that is single dose of injection benzathine penicillin 50,000 units per kg body weight and single dose IM injection can be given as a prophylactic dose for this kind of child. That is clinically asymptomatic as well as VDRL also low titer. If the mother is not treated or inadequately treated or documented of treatment is not evident, we can give curative treatment. So all children born to syphilitic mothers, syphilitic exposed infants should be either prophylactic or curative treatment should be given after birth. Then follow with the newborn child after 3 months, that is 14th week and 6 months, they have ready to clinical as well as VDRL testing should be done. Then manage as per pediatrician guidelines. Next slide. This is basically the congenital syphilis, skin vesicular eruptions, syphilitic rhinitis, hepatitis pneumoniae, lymph nodes there, bone involvement. Then late after 2 years, it's Hutchinson triad, carotid, interstitial carotid, sensory neural deafness, Hutchinson's incisor tooth, the things there. It is a chance of congenital syphilis. Next slide. So final key points. TLD is the preferred regimen for pregnant women living with HIV. Viral load should be taken at 30 to 36 of gestation. Among people who pregnant women living with HIV is done to determine the HIV risk of transmission. Based on their risk, we are giving either to single drug or dual drug for 6 weeks or 12 weeks ARV prophylaxis for the baby. Then EAD, that is early infant diagnosis testing algorithm, should be completed till 18 months of age or 3 months after cessation of breastfeeding, whichever is later. So we have to follow the child from birth to at least 18 months to rule out the HIV infection. Next one. Thank you, ma'am.
Thank you very much, sir, for that really comprehensive talk on limiting the vertical transmission. So I have a couple of doubts. So one thing is that you were saying about the breastfeeding. Right from the beginning, we've been saying breastfeeding must be encouraged and everything. I would just like to know whether it is only there in the developing countries or it's also in the developed countries they are advocating breastfeeding for HIV-affected mothers.
Actually, thing is, you know that replacement feeding means APAS criteria should be there. Affordable, feasible, accessibility, everything should be designed. But as per norms, technically speaking, breast milk has the virus. There is a chance of transmission is higher than non-breastfeeding mothers. But in our area, as you said, the developing area, more chance of other infection like diarrheal disease, respiratory tract infection. Children actually, apart from breastfeeding, only non-breastfeeding children, only 2% of the transmission is there. But still, other remaining 98% of the HIV negative persons also without breastfeeding, they are die of other than HIV, diarrhea, other pneumonia, they are die of HIV in Indian situations.
So that is what I'm trying to ask, sir. So we are all, many of us here, I think, listening to this lecture are all private practitioners. We might be having very affluent patients. So when the affluent patients, when they ask you, okay, I mean, I don't want to give that risk, can I give the formula feed? We are allowed to do so.
Yeah. We have all the luxuries there where even patient itself they can decide about their breastfeeding. But only thing we have to assess affordability. They can continue the safe and healthy. Safety also important. Then hygienically they should prepare and give to avoid infection. As well as co-triamoxyl prophylaxis. I'm not mentioning about co-triamoxyl prophylaxis. If we are starting co-triamoxyl prophylaxis at the age of 6 weeks, it will reduce the other diarrhea, pneumonial infections also. So along with the breast, we can give co-triamoxyl prophylaxis as well as per protocol. We can allow, ma'am. That's the chance.
Now, another thing is that you are, I mean, you are a director and you can, I think, implement certain things. So what we feel is that the HIV, VDRL, everything is done right in the beginning in the booking visit. So even in the government sector and also private sector, also most of the people, they do it right in the beginning. As soon as the woman comes, we do all these tests. So, but given the window period, I think shouldn't it be mandatory to do it again in the end? It should be made mandatory even in the government and, I think I feel that. Because otherwise we won't even know. She might be having and she might be transmitting it to the baby. So for the vertical transmission, we haven't done.
That is theoretically it's possible, ma'am. Window period, it's practically speaking, it's indefinite period. We know that even though first trimester, second trimester, third trimester, we have to, if you repeat the testing for 3 or 4 times, but still after that time they got the infection means we don't know. So, but in government program, I know, I understand your question, but only thing is in government program, the at least once should be tested in the ANC period. This is the government sector. In case of during the counseling or any risk of, for example, any high risk behavior or any presence of STIs or spouses on HIV patient, that kind of area we are repeating. Not routinely we are repeated. In private sector, you can repeat, no other issues. If the patient is actually HIV testing itself, it's not we have to get the consent from the patients. We have to give the counsel pre-test counseling itself. During that counseling, we can we have to aware about their knowledge about HIV and behavior about things. The high risk behavior, we have to repeat even after 6 weeks. That's no harm at all to repeat the testing. In government program, for routinely, we are not able to do all the ANC mothers.
But actually, after I think your previous speaker, Dr. Divya's lecture, I think now almost everybody becomes a high-risk behavior nowadays because we don't even know who is what. So they all look very innocent, and it's all because very much accepted now. Because so they don't feel guilty or anything because it is very much accepted now. So accepted social norm. So I think we really don't know what is high risk behavior now because almost every adolescent and young children, young girls in the college, they are all into high risk behavior only. I feel nowadays the trend has changed. So that is why I asked you that question. So one more question I wanted to ask you regarding syphilis. So whenever anybody comes with, because nowadays we find that it is on the rise, the positives coming up nowadays. So if the woman comes with a VDRL positive, we normally do VDRL. So for whatever. So if she comes positive, so the first thing they say is, okay, so is it really true? So they want it to be confirmed and other things. And we want to know whether there is active infection. So what is the next test to be done? So this is for everybody's information.
Actually, as per thing is TPHA is more confirmatory than VDRL. VDRL is a screening test. If you want to confirm it, you have to go for TPHA testing. But in government program, we are not able to do all the TPH testing for all the TPH facilities only available in medical college, not in other sites area. So we are following the VDRL test as per our government protocol. VDRL actually TPHA means it's if you want to diagnose, it's a part of TPHA is better test, but it's dilutions, follow-up of prognosis, follow-up of treatment, response to treatment, and reinfection, relapse, everything should be based on their dilutions of the VDRL. So VDRL even though VDRL is a screening test, but follow-up activity should be done by VDRL test. So VDRL test, TPHA test, if you have the patient is not accepting the VDRL status, visibility status, I don't have that kind of behavior. I may not get this STI or syphilis there. Go for TPHA test. Otherwise, if the risk behavior is there, with the VDRL itself, it's enough to diagnose and treat. The patient not
Thank you
accepting
very much,
status, go for TPHA testing.
Thank you very much, sir, once again for that excellent talk. Dr. Saravanan?
Thank you.
Yes, ma'am. Yeah, I think you had asked all the doubts that I had also had, because previously they used to tell that don't give replacement, don't be breastfeeding because it is transmitting HIV. And now we have accepted to give them breastfeeding also for those patients, along with the prophylaxis. And you put out the message very well, sir, that we have to reduce the load of virus, and also labor management is also important, and early detection. If you don't detect the babies early, then probably they are going to have more of complications. So that is well taken. Thank you, sir.
Thank you, sir.
Saravanan, only one question for me. Arunachalam, sir.
Yes,
now the incidence of HIV has been reduced or increased, sir?
Compared to previous years, it's going downward, ma'am. Now it's
Going down,
incidence decrease. Yeah, it's a reducing trend is there, but it's unfortunately syphilitic trend, other STI trends are increasing. So we are we have the thought about again we have to get the more number of HIV patients in future. Now it's like
what
LGBT.
Is the incidence in Bihar, sir? In Bihar, what is the incidence?
I will share this one, madam.
No. That's the reason I want to ask. They have mentioned as 400 adolescents, 4,000 adult.
Actually,
yes.
Thing is, Bihar area, actually, compared to Tamil Nadu, they are healthy data.
This is what we got from WhatsApp in the morning.
Around 7,400 people in Siddhamari district, Bihar are tested HIV positive. Actually, thing is, in Salem itself, I'm in Salem, sick for the past 20 years. In Salem, now we have 3 ART centers. 10,000 people are getting ART treatment right now. More than 10,000 patients are living with HIV. So data is like that, but Bihar initially based on data, clear data is not available, ma'am. So initial high prevalence states are only 6 states: Tamil Nadu, Maharashtra, Andhra, Karnataka, and Manipur, Nagaland. Now it's Bihar, West Bengal. These are all showing the increasing. UP, these are all increasing trend is there, because now they are reporting. They are more diagnosing the more cases, reporting there. Now it's Tamil Nadu is going to hyper now, no more at all, no more high prevalence state. Now we are giving to a low prevalence state, coming back to present. Now it's in southern India itself, Andhra is more than Maharashtra itself. So now it's facility diagnosing facility reporting methods should be improved. Now it's Bihar, UP, West Bengal, and Northeast area. We are reporting more number of cases. So, like near recent trend is more on MSM activities increasing now. Men who have sex with men, start from school children, college
but they
children.
have mentioned as 400 adolescents, sir. That's the reason I asked.
Yeah, the adolescent maybe adolescents. Again, I said MSM activity is one of the reason, as well as late direction of the children. With the mother, this kind of EVTHS program is not Tamil Nadu has the good health system, good AIDS care in the government as well as private. But in Bihar, it's less compared to our Tamil Nadu. So more already infected children, those born to HIV mothers, were recently detected. That's kind of things can be happen in Bihar and the other areas.
Okay, sir. Thank you. Thank you, sir.
Thank you, madam. Thank you.
Thank you, sir.
After this elaborate discussion, we'll now move on to our panel. For the moderator, we have with us Dr. Meera Raghavan, who's well known to the Tamil Nadu crowd. She's a senior consultant urogynecologist and robotic surgeon, a proctor and trainer, Hugo RAS robotic platform, has been a convener in TNFOG certificate course in urogynecology and a board certified lifestyle medicine physician. And she's also a national board of specialist committee member, treasurer in the SOVSI, the Vaginal Surgeons of India Group, Tamil Nadu chapter, core committee member and faculty in the Urogynecological Committee of FOXY since 2015, and she's been the scientific chair, AICC RCOG in 2025, a national board coordinator and examiner, MRCOG trainer and examiner, and a director, Ascot Apollo Stimulation Center coordinator for obstetric skills. She's also a winner of 32 gold medals in the undergraduate curriculum and also the best outgoing student in her PG from PGA Chandigarh. Over to you, ma'am. Very happy to have you here for the panel.
Thank you very much for the kind introduction. Thank you.
Ma'am, you want me to introduce the panelists or you'll go ahead, ma'am?
Yeah, I'll go ahead. Thank you.
Thank you.
My esteemed panelists, I welcome them and I thank TNFOG, Dr. Vidya Prabhakar and Dr. Sampath ma'am for this opportunity. I got to read up a lot and thank you for this wonderful learning exercise and homework. Dr. Pungodai Selvaraj, Managing Director, Divya Hospital from Tripur and Founder President, Tripur ONG Society. With special interest in ART and laparoscopy and high-risk obstetrics. Welcome, madam. Dr. Anita Tamarai Selvi, who is Professor and HOD of Government Dharmapuri Medical College Hospital and President ONG Society Dharmapuri with high-risk obstetrics and social obstetrics as the prime interest. Welcome, Dr. Anita.
Good evening, ma'am.
Good evening. Dr. Padma Priya, who is now currently at assistant at Government Karur Medical College and also got Best Doctor Award and Best Doctor Award from the Collector Karur during the current year. Happy to have you here, Dr. Padma Priya. Welcome.
Good evening, ma'am. Welcome. Good afternoon.
Yeah, my bestie and my partner in crime and pride, Dr. Meena Mahalingam. Welcome, Meena. She must be traveling somewhere or operating somewhere. So welcome the panel, and Dr. Radhika Gauri, who is also a good friend, who has got wide experience both in NHS and here, who is a TNFOG coordinator in 2023, and with special interest in high-risk pregnancy, adolescent obesity, and minimal access surgery from Tirunelveli. Welcome. So it's very important that we do not overlook vulvovaginal disorders, especially infections. So which is why this very clinically relevant panel has been designed. So the first case will be going to Dr. Pungodai, a recurrent vulvovaginal candidiasis. This is not just for diagnosis, but for us to go through the important nitty-gritty details. 32-year-old, 6-month history of recurrent itching and curdy discharge. Even a first-year intern would say the diagnosis looking at it. As I emphasize, it's not for that. It's going back to basics. She's had 5 episodes in 6 months with partial relief with the OTC, over-the-counter azoles. This is a common practice everywhere. Even without examining, people get this done. So, which is why I have put this case as the first one. So, madam, we know the most likely diagnosis. What is your differential diagnosis? Which investigation would you do? What about the counseling? And when would you refer to another specialty? And how are we going to follow up?
So this patient is a case of recurrent vulvovaginal candidiasis. The differential diagnosis are bacterial vaginosis and trichomonas vaginitis. So we have to differentiate vaginal candidiasis from trichomoniasis and bacterial vaginosis. From the history, from the clinical symptoms, the patient will have intense itching and there will be complaining of curdy white discharge. And on examination, there will be vulval edema, excoriations, erythema, and on speculum examination, we could see the discharge. If it is trichomoniasis, it will So frothy discharge, greenish frothy discharge, and strawberry vagina will be seen. And in case of bacterial vaginosis, no signs of inflammation will be there. And the odor, it is a malodorous discharge, fishy discharge. So from the clinical features, and we have to go for investigation. The pH will be normal in case of vulvovaginal candidiasis compared to trichomoniasis and bacterial vaginosis. So this is the most differentiating point among all the three. And microscopy. Microscopy confirms actually microscopy is of saline preparation KOH. We can see if it is trichomonas vaginitis, we can see the flagella, and if it is vulvovaginal candidiasis, we can see the hyphae with the KOH preparation. And bacterial vaginosis also, we can see the clue cells actually. And so if the microscopy is negative, then we have to go for culture. By fungal culture, etc.
The very important fact is the patient herself will say that it is smelling very acidic. So the vaginal pH does not become alkaline. It's far worse acidic than even the normal pH. And the risk factors may be obesity, prediabetes, or diabetes. And nowadays, people wear these leggings. This itself is a high risk factor for recurrent vulvovaginal candidiasis because there's no breathing of the skin or the portion there. And especially in a tropical climate like ours, this is an issue. And frequent antibiotic usage. All viral infections, especially of the upper respiratory tract, if they are unnecessarily treated with antibiotic, especially broad spectrum antibiotics like augmentin or azithromycin, they immediately can get candidiasis. And that is why probiotic recommendation should be there, or judicious use of broad spectrum antibiotics should be done. People who are on steroid medications for other reasons, people who are on immunosuppression, especially post-renal transplant or liver transplant patients, chemotherapeutic patients, and patients who have who are on medications for diabetes, especially the GLP-1, like the not the GLP-1, the gliflosins like the dapagliflozin or the empagliflozin, which act by causing glycosuria as a method of diabetic control, are highly prone for recurrent vulvovaginal candidiasis. This is something we need to elicit from history. So basically going back to your fundamentals of history taking, a thorough examination is very, very essential. And the differential diagnosis could be a non-albicans type of candida. We get to see, being a urogynecologist, especially with a lot of referrals from other specialties, I do get a lot of candida glabrata or tropicalis. So it is very, very important for us to appreciate that somebody with a recurrent vulvovaginal candidiasis might be resistant to the fluconazole and might be presenting with candida glabrata, especially if they are immunosuppressed. So the management is fluconazole induction and a 6-month suppressive therapy, and important advice about lifestyle, and review after 6 weeks if it is still persistent. We have already gone through these as Madam clearly explained. Yeah.
If it is still persistent, can we continue, ma'am, suppressive therapy?
Yes, we should be continued, which is what I'm going to come to. So the investigations, as we've already mentioned, and do not forget your HbA1c to evaluate for diabetes. So induction therapy is fluconazole 150 milligram every 72 hours for 3 doses, and maintenance fluconazole 150 milligram weekly for 6 months, provided it is just Candida albicans. If you have missed out on Candida glabrata, it will not respond to this. I'll tell you what next to do for that. Boric acid capsules will be good for non-albicans species. These are available online as well. 600 milligram for 14 days, but mainly lifestyle and continue probiotics. These are known to be proven effective methods for prevention of recurrent vulvovaginal candidiasis. Partner treatment is not routinely required. However, if the partner is diabetic, the partner has to be sent to a urologist to rule out the presence of balanoposthitis, and that has to be effectively treated. And the effective treatment for balanoposthitis is circumcision. So recurrent vulvovaginal candidiasis is more than 4 episodes in a year. Always evaluate triggers such as diabetes, presence of broad-spectrum antibiotics recently, estrogen, especially birth control pills. People who are on HRT or birth control pills or not using their estrogen vaginal cream properly can be candidate for recurrent vulvovaginal candidiasis. Non-albicans candida accounts for nearly 1/5 of the patient and needs proper different therapy, not the fluconazole. Long-term suppressive therapy is effective, but anticipate relapses. Reconsider diagnosis symptoms are atypical or persistent. The second thing which I would like to tell is the age-old method of local gentian violet vaginal treatment is a very good method to treat recurrent vulvovaginal candidiasis or non-candid albicans treatment. So the first step is to confirm infection, identify species, identify triggers, and abate the triggers, induce therapy by fluconazole regimen, maintenance therapy, and reassess if there is persistent symptoms. The second case, Dr. Anita Madam, 29-year-old with foul-smelling gray discharge, no itching, recurrence is post-menses.
She has no other symptoms except the smell. The nature of the discharge is also suggestive of vaginosis, bacterial vaginosis probably, which can be confirmed by Amsel's criteria, where we have to look for the pH, which is alkaline, and blue cells, and a whiff test may be positive. And
it's an alkaline pH, correct. Thank you. Yeah.
Okay. Then we can do the tests, which will rule out other wet mouth and other things, will rule out the other causes also, and we can go ahead with the management with metronidazole.
Yeah.
500
Why is it
DD
so
for
important? Why is bacterial vaginosis so important?
It may land up, if it is untreated, it can cause complications during pregnancy, preterm labor, PROM, and after surgery also it may result in infection, post-operative infection, post-abortal infections. So the normal bacterial flora, if it is altered, it may land up in infections after any procedure in the gynec area.
Yes, it is basically a preponderance of the anaerobic bacteria in the vagina as opposed to the usual commensals, which or the lactobacillus, which is why this is happening. So vaginal microbiome, gut microbiome also play a huge role in the prevention of bacterial vaginosis and prevention of recurrence as well. So that is the most important thing. Dr. Padmapriya, third case, 40-year-old with frothy yellow discharge dyspareunia, strawberry cervix on examination. This is basically a stipple cervix typically happening. Your questions. I think Dr. Padmapriya.
So in the cervix is, shall I answer, ma'am?
Yes, please, go ahead.
Probably she's not there. When the, she's not.
Okay.
Yes, ma'am. When the cervix is inflamed, edematous, it is usually due to trichomonas infection, which can be confirmed by doing a wet mount, where you can see the motile trichomonas, motile flagella, which confirms the diagnosis. And this needs to be again treated with it is metronidazole 2 grams, and it is a sexually transmitted infection. We need to treat the partner also. The look of the cervix, which is edematous and red, and the symptoms also makes us to suggest the diagnosis and confirm it by wet mount. Simple wet mount will confirm the diagnosis of motile organisms, after which we can treat them.
Yeah, this is a case for contact tracing, and STI screen is totally recommended because this is a sexually transmitted infection, and treatment of the contact of the partner is mandatory for this. Dr. Meena, a 52-year-old with postmenopausal with burning dyspareunia and a purulent discharge, not just UTI-like symptoms, but a discharge as well.
So, as you have mentioned, madam, it is a desquamative inflammatory vaginitis. Most likely, it could be because of the estrogen deficiency, how we tell about genitourinary syndrome of menopause. Here, it could be a predominance of the parabasal cells. So, there can be desquamation, occurs mainly in women who are in the perimenopause or postmenopause. We need to differentiate from other chronic conditions, just not thinking it is due to desquamation of the cells. Here again, in the routine testing, we will be looking for the pH. pH usually will be on the alkaline side, and there will be loss of the lactobacilli, which is going to be a protective factor. And if we take a smear and put it on the glass slide, we'll be observing the neutrophils, and also microscopy, we can see the parabasal cells. We need to differentiate from, because of estrogen deficiency, hypoestrogenism, a genitourinary syndrome of menopause, where there may be associated recurrent urinary tract infection, and lichen planus, again, autoimmune disorder, and chronic candidiasis, which we have dealt in the first case. So here, after ruling out other causes, we have to start them on local vulval hygiene and give them the vaginal estrogen, which will be main treatment, as it is likely to be a estrogen deficiency, and later we can give a clindamycin cream. Main thing is long-term monitoring is required based on the symptoms, whether there is itching, there is extensive pruritus. We need to think of other chronic conditions as well.
Yeah. Thank you, Meena. The point here is some subset of patients will present with discharge. Certain subset will present with vaginal itching. Some patients will present with burning sensation in the vagina, and some patients will present with pain in the vulvar area. Each one has to be dealt differently in an algorithmic way, because not all of them will be zooming into one diagnosis. Discharge could be totally infection or neoplastic in nature, whereas the burning or the pain and the itching could be related to an atrophic vaginitis or a desquamative vaginitis. So we need to clearly listen to the patient and a proper inspection in good lighting and good exposure, because majority of the patients do not know the difference between vulval itching or an irritation. They always tell it is in the private part. They don't tell it whether it's inside or on the outside or even in the groin. For them, everything is down below. So it is important for us to elicit a thorough history and a clinical evaluation by proper examination, palpation, and good speculum examination and good lighting with adequate exposure. That is why I put this. This is similar to atrophic vaginitis. The patient does not get enough response with vaginal estrogen. Go back and examine again and add clindamycin. They might be able to get better. Dr. Radhika Gowri, 58-year-old with dryness, pain and burning and recurrent infections. So your questions are up here. Dr. Radhika?
So, Madam,
Can
yeah, and if Dr. Pungode can take it up, please.
This is a case of atrophic vaginitis or genitourinary syndrome of menopause. It is because of lack of estrogen causing atrophy of the vaginal mucosa. So the management is vaginal estrogen, local vaginal cream, and also we can prescribe probiotics also.
Yes.
And
Yes.
moisturizing creams.
Yes.
Used.
When we prescribe moisturizer, be very careful only to prescribe isoosmolar moisturizer. Most of them, which are commercially available, can be hyper or hypo and cause difficulty for the patient and worsening of the symptoms. So anything which is hyaluronic gel based will be good. We get something called Replens MD, which is a very good moisturizer available online as well, though it is pricey, but it will last longer. Vaginal estrogen is the cornerstay of treatment for atrophic vaginitis. It can be used as long as it takes to abate the symptoms. Though the studies are only available for a year of its usage, there is no contraindication to long-term usage. Now we also have ospemifene, but it is not widely available here as yet. And long-term therapy improves sexual function as well. And just today in my clinic, I've seen a 72-year-old lady who has symptoms of severe burning, and she thought it is UTI, and her sister, who's a gynecologist, has been prescribing antibiotics. She's not getting better, so she came. The entire vagina and the urethra is sealed. There is no space or opening there. So I had applied Emla cream and subsequently done adhesiolysis and separated the whole area and given a lot of local anesthetic plus estrogen cream. This goes to show how severe an atrophic vaginitis can be to cause complete synechia and adhesions and closure of the intritus as well as the urinary part. So it is important for us to have a thorough examination and just not prescribe antifungals or creams and things like that. This is for probably Dr. Pongode and Dr. Anita, a 60-year-old with severe itching, silvery ivory white plaques with a figure of 8. Literally, it starts from the vagina and goes down to the anal canal.
It is lichen sclerosis.
Yes, ma'am.
And
since it's postmenopausal 60 years old lady, we have to rule out squamous cell carcinoma, ma'am. There is a 4 to 6% risk of squamous cell carcinoma. So first we have to rule out that, and if it is proven that it is not malignant, we can go ahead with steroid treatment. And
yeah, not always do we need a biopsy, but if it is not getting better, or if there is a raised plaque or an ulcer, or you see any suspicious areas, then we'll have to do a biopsy, including a wedge biopsy with the adjacent proper area. It is clobetasol regimen, which is long-term and for maintenance. So do not tell the patient, if you stop itching, do not use the cream. They have to continue the cream to reduce the inflammation, but in a sparing manner, because these are steroid creams. They also thin down the epidermis and can give rise to complications. And the most important advice to these lichen sclerosis patients are they have to be on follow-up every 6 months. Whether their symptoms are persistent or not, they have to come for follow-up, and an examination, even with the colposcopic machine, with the bulboscopy, is crucial so as to pick up those possible areas of coexisting VIN or progression towards squamous cell carcinoma. Always investigate for hypothyroidism and diabetes and pre-diabetes in a patient with lichen sclerosis, because these are known to be coexistent along with the lichen sclerosis and known to aggravate the symptomatology of lichen sclerosis. Thank you, ma'am. Dr. Anita has also already answered. It will be Dr. Meena. Lichen planus, which is a 45-year-old erosive bulbar pain and dyspareunia. See the difference between a lichen sclerosis and this. This is red and angry with white striae, whereas that one was different. Meena, your questions?
So the most likely, as you have already mentioned, it is lichen planus, madam. So you have already told about the erosive lichen planus. So we do have 3 different types, like erosive. In this case, it is the most common type in lichen planus. You will have bright purple Wickham striae. That is the main thing. Lacy line will be there, and there will be redness, and there is extensive lichen planus can cause vaginal stenosis, and as it is an autoimmune condition, as you have already mentioned, we need to look for other autoimmune conditions as well, and it can also happen in other sites. We need to look for oral cavity because it can be there as lichen planus in the oral cavity, and if it is not responding to the routine treatment of lichen planus like potent steroids, tacrolimus, in that case, we may need to do a biopsy, as there is a chance of having a malignancy if it does not respond to the treatment. Usually these women have postmenopausal bleeding, discharge, dyspareunia because of the stenosis. So it is important to ask about the quality of life, the sexual life in these women, and treat them accordingly. As you have already mentioned, examination after the proper history with the proper lighting to look for the lesion, the Wickham striae and the erosive papillosquamous ulcerative lesion is very, very important. And then if needed, non-responsive cases, we do take a biopsy.
Thank you. This is a mucosal disease. So look inside their buccal mucosa, the lips as well. They will have these red erosions which become striae. So that is a clue to clinch the diagnosis of lichen planus. And tacrolimus topically is a very good potent way to treat it more than the steroids itself. And this is a long-standing painful condition. Unlike the lichen sclerosis, it's really painful. These patients suffer quite a lot and it gets aggravated by stress factors as well.
And my father-in-law also had this, madam, in the mucosa.
Yeah.
And it was non-responsive and we had to take a biopsy of the buccal mucosa.
Yeah, because we need to rule out submucosal fibrosis when it happens in the buccal. So it can become precancerous if it is submucosal fibrosis. So
and
it is very,
5 Ps for this pruritus, purplish.
Yes.
So it looked purplish in that area, lichen planus.
Correct. Yeah. So the lichen sclerosis, the presenting symptom is severe itching, whereas in lichen planus, the severe problem is painful ulcerations. That is very, very important for us to diagnose. This question will go to Dr. Radhika Gauri, if she's there, or Dr. Pungodai back again. 30-year-old chronic itching worse at night.
This is again a dermatological condition, chronic vulvar dermatitis.
Many patients come with this. Many
Yes.
patients. Why? Madam, can you elaborate on that?
They use soap.
Because of contact
soaps,
dermatitis, actually,
Yeah.
due to the
to
detergents.
clean it.
Yeah, they use a lot of perfumed products, especially with the commercially available preparations, which many people are propagating. Many of the GPs also propagate it. Totally dissuade from using any of these commercially available washes. And second thing, the lot of hair removal creams, the razors, allergy to those, these can also cause our panty liners constantly. Those all contribute to chronic vulvar dermatitis. Yes.
Even the panties, they don't.
Yes.
And also the wet wipes, generally they use the
Alco wipes.
latex, the soap, the detergents, and also the topical medications.
Yeah.
Like
It's not an uncommon problem. This is a very, very common problem in youngsters as well. So very, very important for us to identify this. This one.
This is
It's again.
Dr. Anita?
It's
Dr.
again
Meena. Yeah.
infection of the follicles, ma'am.
Yes.
Follicular dermatitis.
Yeah.
Then that.
Not uncommon
Mainly
with our obese
because of
diabetic
obesity
patients.
and women who smoke, especially
Correct.
can be between 20 to 40 years and more common in the women than in men. And especially the local hygiene. Nowadays in women with polycystic ovarian syndrome, with metabolic syndrome, obesity, this is very common because of follicular occlusion. Generally, there is a tetrad where, like we say, hydradenitis suppurativa, like that pilonidal sinus also there, and acne conglata and dissecting cellulitis of the scalp. These are the 4 things which we say about follicular block, especially when we are using a razor or anything, the follicle which is secreting gets blocked and this tends to become enlarged. That is a main pathology and happens with the apocrine glands. If it is not getting controlled by our own immunity, if there is a decrease in the immunity, it can lead on to abscess formation, tender, painful. It may open by itself. If not, we may have to drain it. And if sometimes there can be sinus tracts which open to other sites as well, causing later fibrosis. So this is very, very difficult. And here again, we have a classification for this early classification of 1, 2, and 3, where stage 1 is single or multiple abscesses without tunneling or scarring. Stage 2, you have just put the diagram also, ma'am. Recurrent abscesses with tunnel formation separated by normal skin. We can see different opening sites and numerous abscesses across a large area with no normal skin separation. This is mainly we have to have a stopping smoking, like lifestyle changes. Mainly it is lifestyle medicine. Stopping
Is
smoking.
it more common in the vulva or in the axillary region, ma'am?
Both, madam.
It is common in all the areas where there is excess follicle.
Hair follicle.
Hair follicles.
Especially If it is a diabetic patient, it is in the mons pubis and the vulva. If it's a younger patient, it tends to happen in the axillary armpits.
Wherever we are not exposed to the skin, like we are covering that area, like in the perineum, where there is axilla.
Or the back.
And buttock.
Area,
All the
yeah,
areas.
the sacral area.
They'll have painful
Most important thing is if a young adult has like a paronychia or hidradenitis, which is recurrent, or has pustular acne or recurrent candidiasis, this should immediately alarm us testing for diabetes or immunosuppression. It is not something which is, just treat and get on with it. This has to be addressed and lifestyle has to be addressed. Otherwise, this is an indication of a metabolic syndrome. That is the main message.
Is it immune mediated, madam?
It is immune mediated as well because of the certain amount of immunosuppression, which is what I'm going to come to. So weight loss, avoiding tight clothing. I think we should strongly advocate against very tight undergarments, synthetic undergarments, the lycra which people use, the fitness clothes which they use. This has to be breathing in nature rather than tight.
Even the night dresses, they don't use the common night dress we use.
They need to have
wear a pant.
Skirts. They need to wear skirts which allow it to breathe rather than occlusive ones. This is something we need to educate our younger adults as well. And the topical antibiotic zinc is known to be preventive as well as for treatment because it enhances the healing process, and systemic antibiotics like tetracycline. If it is more than 2 to 3 episodes, I tend to add rifampicin to the management because rifampicin is a really good staphylocidal antibiotic, and it helps the management of the carrier status as well. Always, if there is continuous pus discharge which is not settling, do your MRSA testing as well. That is very, very important. More aggressive therapy has now come in, especially for people with recurrent hidradenitis. It is unbelievably painful. These patients suffer a lot, especially when they have in their armpits as well as in the mons. It's not easy. We have had debulking, excision of those fatty necrosed areas in obese women. It is not pleasant to do that surgery at all because it can be quite vascular and necrosed. So adalimumab is a good boon which the dermatologist also prescribe for recurrent hidradenitis suppurativa along with laser. But laser should not be done when there is active infection, and only after completely treating the infection should laser therapy be done for the hair follicle, not for the hidradenitis suppurativa. So tetracyclines, mainly doxycycline for anti-inflammatory effects and clindamycin and rifampicin combinations. Humira, which is the biological, is very good method for treating recurrent hidradenitis. We know about the surgical options. Definitely oral zinc corticosteroids, Botox injection in those areas for hyperhidrosis. Apart from using aluminum chloral hydrate, which is an antiperspirant, it is also Botox, which can be used to reduce the hyperhidrosis, which can lead on to this worsening of this. So avoid talcum powder and direct deodorant application in the areas where it is prone for hidradenitis, because as Meena clearly explains, these go and block those sebum channels, and that is why causes inflammation of the glands. So direct deodorant application or direct talcum powder application is not advisable. This has to be educated as well in a tropical country like us. I don't need to tell, this is our bread and butter. If Dr. Radhika is not there, can somebody
Radhika
take
is
this?
Madam.
Dr. Radhika?
Yes, ma'am.
Yeah, this
I'm
is
here,
your
ma'am.
question.
Sorry, I was driving.
No problem.
Yes, ma'am.
Painful vulvar swelling and what is this?
Yes, ma'am. Sorry, I'm just on the.
It's a Bartholin's abscess.
Bartholin's abscess. Yes, ma'am.
We will only give, yeah.
Yeah, we have to. If it's an abscess, obviously we have to do a IND. incision and drainage after starting the antibiotics, and take it to theater, and then, marsupialization. If it's recurrent, we need to do a marsupialization.
Yeah.
Otherwise, we can do a straight IND straight away. We have to tell them that if we do IND and it might recur, that is the other thing. And they have to keep hygiene is very important. And as usual, the tight clothes also can cause, it is not only sexually transmitted, it can also be due to other usage of pads, etc. But the sexually transmitted infections are more common. So we have to tell them to use condoms to prevent recurrent infections. That is the main point, ma'am.
Yeah.
So one more
Dr.
thing, the incision what we place should be on the
inner aspect.
Inner.
Previously,
Yes.
we were telling put it on the junction, and also elliptical incision if you are going to excise.
Yes.
And also word catheter.
Exactly.
If it is not available, we usually insert what is
also-
available in our setup, glove piece, or just to keep it draining. And
we put a wick, cotton wick, or a
Wick,
Foley's.
yes, ma'am. We put a wick.
Wick is
Absolutely,
betadine soap
yes.
wick, or you can put a Foley's if you're worried
Foley.
about the bleeding. So that
Yes,
should
ma'am.
take care.
also be used.
Yeah. Skene's gland infection. This is the 38-year-old periurethral pain swelling in the spirulia. This we see quite often. Typically happens after periods. They say, I come with a swelling, it bursts on its own, but it's so painful, I can't pee, all those conditions. How would we differentiate this from a Bartholin's? Because people who see otherwise say it's a Bartholin. So,
the
site,
lower
the site of the swelling.
The location.
yes, ma'am. This is anterior adjacent to the urethra. The Bartholin's is in the posterolateral aspect of either side of the vaginal introitus.
4 o'clock and 8 o'clock position.
So the differential diagnosis between the Skene's abscess is the urethral diverticulum. The treatment is IND and gland excision for recurrence.
Usually, in the urethral diverticulum, the patient will have the 3 Ds.
Dribbling,
dribbling, post-maturation dribble, and dyspareunia will be there.
And it's painless also, ma'am. Painful, diverticular.
If it's infected, can be painful. Yeah. What will happen is if you press on that, they will have discharge through the urethra. So that's one way to find out it's a diverticulum. It tends also sometimes, unlike the Skene's. This is a 36-year-old smoker with persistent vulvar lesion. This is the vulvar lesion.
So we have to do vulvar biopsy to rule out vulval intraepithelial neoplasia.
Yeah.
Here, VIN, usually we have 2 types. The HPV related and non-HPV related. HPV related usually occurs in younger women. That is called the usual type. And the non-HPV related usually happens in the elderly women. Here, HPV related will respond better because younger age HPV treating the infection will settle. But differentiated lichen sclerosis related, which happens in an older woman, has got a worse prognosis.
Yeah, it's biologically different.
Yeah. So it is like our CIN. We need to just identify the vulvar intraepithelial neoplasia using usually Tolidin blue. And like we use via villi for the cervix. Here we use Tolidin blue, identify the area and then take a biopsy. And then based on the biopsy report, we go for the excision. Generally, we do not use medications. If it is excisable, we do complete removal of the VIN and then surveillance will be done because there is a chance of recurrence. The younger women, they will respond, but they have to be kept under follow-up. Every 3 to 6 months, we may have to follow them up like how we follow for CAN 1, 2, 3. We have to follow them up. CAN, like we have to follow up WIN every 3 to 6 months for the first 2 years, then 6 monthly for the next 2 years. Annual follow-up should be kept for VIN.
Correct. Absolutely. And the most important thing here to appreciate is the VIN is a field disease. So it can happen anywhere around that area because it's HPV mediated, and vaccination has to be advised because it will prevent progression of the VIN as well. And because it's a field disease, will prevent HPV related occurrence elsewhere. So it is an immune mediated. So that is why. So these are the important take-home points as far as VIM management, surveillance, etc. are concerned. 70-year-old with a non-healing ulcer. Anyone can take it.
Early vulvar squamous epithelial cancer is similar to type 1 vulval cancer. In that we say the size of the lesion is less than 2 centimeter and stromal invasion is less than or equal to 1 millimeter. The main thing is in type 1 early vulval squamous cell carcinoma, there may be less chance of having a lymph node involvement, that is less than 1%. If the size of the lesion is very small, we can go for a wide local excision. We generally send it for biopsy having a margin of around 8 millimeter. For getting a margin of 8 millimeter, we have to take a biopsy including 1 centimeter.
Yes.
So if the margin is negative, we can just keep her and follow.
Yeah.
And if there is a lesion which is extended beyond the margins, then we may have to plan for a next surgery. The wide local excision will not be sufficient. We may have to do radical vulvectomy. That meaning it is not early vulval squamous cell carcinoma. It is advanced. From 1A, it has become more than 2 centimeter, more than or equal to 1 mm stromal invasion. There is a high chance of lymph node involvement. We may have to do vulvectomy, and if required, we may have to do unilateral lymph node.
Yeah.
If it is spread, we may have to do bilateral lymphadenectomy.
Yeah.
We call that triple incision butterfly.
Yeah, but nowadays,
Yeah,
what we had to do radical vulvectomy with that big groin dissection where they had lymphedema and extensive wound breakdown when we were trainees and postgraduates. Now we have, because I'm a robotic surgeon, we have robotic veil where we lift up the thigh, we put ports in the thigh and take out the lymph nodes from the groin. This has excellent recovery rates. Patient can walk straight away after 2 days, but they will have compression stockings. It does not have any breakdown because it is not in that vulnerable area where we have to stitch with a lot of pressure down there. So radical vulvectomy combined with the robotic veil excision of the nodes is being done, where it offers a very good recovery phase and no wound complications as well as these. Most of these patients will be obese, diabetic, comorbid conditions, so on and so forth. So it is beneficial from that point of view. I just wanted to highlight how things have advanced in the management of vulvar cancer.
Not seeing
nowadays.
the robotic excision, maybe you have to play a video for us.
I will definitely.
We generally plan the triple incision, one in this groin, one
we
in
used to do that, but now thancefully we do that. This is a very unusual case, but I have seen 3 or 4. A 41-year-old labial swelling with draining fistula. This is secondary to a Crohn's vulvar fistula, where the Crohn's abscesses, which happen as perianal abscess, have broken down and fistulized into the perineum anteriorly. So it can present periurethral, it can present in the mons, it can present in the labia, it can present in the vulva, it can present in the perineal body. So multiple, it will be literally like a water can perineum. The two main differential diagnosis for this is TB and Crohn's. TB will be caseating granuloma, Crohn's will be non-caseating granuloma. The point of reference here, which is a take-home message, is if you find a fistula coming anteriorly, it is not a Bartholin's abscess which is broken. People rush in to go and doing something. No, do a MRI perineum with contrast. You will be able to see it is actually a high anal or perianal or intersphincteric abscess which has transversed into becoming a perineal or a labial or a vulvar fistula. So if there is recurrent and in a younger patient or immunocompromised patient, it could be Crohn's or TB. It is not uncommon. I have seen quite a lot of these patients, and it is very important to do the imaging correctly without jumping into as if it is a Bartholin's, because these patients will recur immediately and will have pus coming out from all sides of the vulva. So that is very, very important. And treatment, obviously now biologics are excellent for any Crohn's related fistula. As a urogyn I do see in patients with recurrent UTI, if they're having a burning urination all the time, do think of intravesical or Crohn's or ulcerative colitis related colovesical fistula. It is not uncommon. Constant pyuria in a inflammatory bowel disease patient with very burning, like acidic urine. That means the patient has some fecal discharge into the bladder. If you do a cystoscopy, you will be able to make out. After treatment of that, if they are put on biologicals, this completely regresses. So it's very, very important for us to be highly suspicious of these uncommon presentations as well. So to wrap up, thank you very much. Very interactive panel. Thank each one of you for your active participation. And thanks Dr. Vidya Prabhakaran and Dr. Sampath ma'am for giving us this assignment of learning further about the vulvar and the vaginal infections. So points to reiterate, chronic vulvar symptoms need thorough examination. So history and examination, there's no cutting corners. Use your pH, microscopy and cultures and biopsy judiciously. Differentiate between infections, inflammation, pre-malignant and malignant condition. Understand that lichen sclerosis is not a one-off. It has to be monitored. The patient has to be under surveillance. Multidisciplinary approach always improves outcome. Always ask your dermatology friend, and they might be able to help you with the recent advances in it as well. And patient-centered counseling is essential, and lifestyle has to be emphasized in majority of these cases so as to have better outcomes. And thank you for the opportunity.
Thank you.
Veera, you have two questions in the panel.
Yes, ma'am.
Two questions in the chat box. Post-menopausal bleeding, PB, estrogen, how long has to be used? And atrophic vaginitis, how will you counsel?
Okay. Long-term vaginal estrogen in postmenopausal bleeding is not a contraindication, but investigate the postmenopausal bleeding and rule out an endometrial cancer. Postmenopausal bleeding, only 10% of them will have endometrial cancer. The rest could be due to atrophic vaginitis itself. So the answer to your question is postmenopausal bleeding is not a contraindication to local estrogen. Investigate your postmenopausal bleeding, rule out endometrial carcinoma. If it is not endometrial carcinoma, continue your local estrogen as long as it takes till it benefits the patient. The next one is how will you counsel?
Atrophic vaginitis.
First, tell these women not to sit for too long. Most of them are at home sitting on the sofa watching Sun TV for a long time or going to these satsang or sloga classes. That itself worsens the atrophic vaginitis because it's under pressure. Ask them to use a piles cushion or a donut cushion if they're wanting to sit because the perineum doesn't get pressed. Ask them to use plenty of non-fragrant coconut oil. உடனே பேஷண்ட் கேட்கும் செக்கு எண்ணெயாங்க ஏதோ ஒரு எண்ணெய் அது பேராஷூட்ல அந்த வாசனை வரதா இருக்கக்கூடாது. Constantly use coconut oil. Ask them not to wash. Our women have this habit of, because this is atrophic vaginitis, they will go to the washroom very frequently thinking it is urination, and they'll keep on washing with a hose pipe. That will worsen the dryness and they'll get burning. So ask them to liberally
with the hot water.
Hot water, yes.
With the hot water.
Yes. And ask them to apply plenty of coconut oil and the estrogen cream with the finger and start it from the clitoral area, inner aspect of labia and the foreshape. These are the worst areas where hypoestrogenism affect. Majority of them will shove it in and hope it will all disappear. No. Apply it where it burns. It cannot be more explicit than this. எங்க எரியுதோ அங்க போடுங்க. அது புரியாதவங்களுக்கு அதை நம்ம தான் சொல்லி கொடுக்கணும். So these are the
keep
ways
it in the
we
fridge
would.
and apply.
These are the ways
Coconut
we should. Yes. Coconut oil அது பண்ணாக்க ஒரு பாட்டில்ல குத்தி வச்சுக்க சொல்லுங்க. அது உறைஞ்சு போயிடும். So paste மாதிரி எடுத்து அப்ளை பண்ணிக்க முடியும். And you can always mix it with lox jelly or a lignocaine jelly so it affects anesthetic effect as well. So
thank you, Meera. Fantastic. So hereafter all Thursdays I will call you for moderating the panel.
Thank you.
I have excellent panelists, madam. That's why.
Same panelist also we will call. The same panelist also we can call.
Excellent panelists. So.
Okay. Adita, Pungo, Deva, Meena.
You made us read a lot, ma'am.
Yeah, thank you.
Okay, fantastic.
Thank you, Sampath ma'am, Meera ma'am.
Thank you.
Thank you, ma'am.
It was a very nice time. We had learnt a lot, basically.
After a long time, I'm seeing Meena sitting on a chair and doing a webinar.
Otherwise, she will be driving. Always driving.
Driving. Thank you,
Anyway,
ma'am.
Gayatri, formal
Thank you,
vote
ma'am.
of thanks. Gayatri.
Yes, ma'am. She's left actually. I'll do the vote of thanks, ma'am.
Yes, all in all.
Okay, ma'am. Thank you, ma'am. Sorry, I was also away driving. That's why I couldn't join the early, ma'am.
மீனாவெல்லாம் நீ போட்டி போட்டு தோக்கடிக்கவே முடியாது டிரைவிங்ல.
ஆமா சிட்டி டிரைவர்ல. ஓகே மேம்.
சரி,
Thank you.
மீனா ரொம்ப நல்லா இருந்தது. கிரேட். வித்யா மேடம் ஏதாவது இருக்காங்களா? எதுவும் சொல்லணுமா? டாக்டர் வித்யா பிரபாகர் மேடம். எனிவே, எஸ் ராதிகா, vote of thanks.
Yes, ma'am. So coming to the vote of thanks, I thank all the delegates who have attended this fantastic program. Hope they have been benefited. A lot. I thank the Tnfog team, Dr. Sampath ma'am, Dr. Vidya ma'am, Dr. Saravana Kumar sir for giving us this opportunity. I thank the chief guests, Dr. Lakshmi Shrikande ma'am and Dr. Madhuri Chandra ma'am, who made themselves available for this valuable, informative webinar. And I thank the judges, Dr. Shanti and Dr. Kartika Prabhu, who every time they spend their valuable time with us and they have moderated the session. In the done by the UAS, Dr. Sasireka and Dr. Divya. Both the sessions were fantastic. And then the next session was done by Dr. Arunachalam sir. And that was also a fantastic session regarding elimination of the vertical transmission of HIV. Thank you again, the chairpersons Vidya ma'am and Saravana Kumar sir. I thank the moderator Meera ma'am for a very excellent session on vulvovaginitis. We all have learned lots of points from her. Thank you, Dr. Pungode ma'am, Dr. Anita ma'am, Dr. Padma Priya, Dr. Meena ma'am, and who have been active. And the program was moderated fantastically well by Dr. Meera ma'am. I thank Dr. Gayatri, who is my fellow MOC, and who has moderated this session. Thank you so much, Dr. Miss Sahiti and Sri Priya for the IT support. Thank you so much, ma'am. Thank you,
Thanks,
Sampath ma'am.
Radhika, for MOC and be the panelist. Thank you.
Dr. Radhika.
Sorry, ma'am.
Thank you, Radhika.
Thank you, Meera ma'am.
Thank you, Radhika.
Thank you, ma'am.
Thank you, ma'am.
Thank you, Meera ma'am. Thank you.
Thank you all.
everyone for the night. Thank you.
Thank you so much, ma'am.
Thank you, madam.
Bye, 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 bye.
Yes, ma'am. Thank you, Sampath ma'am.